session. I appreciate you joining us. Before we get started, I just really would like to formally recognize all of our sponsors, but primarily recognize Kent Imaging. Kent is a platinum sponsor of the meeting. They really put a lot of effort in this meeting, and we can't do this without our sponsors, and I just wanted to thank Kent Imaging for really stepping up to the plate. I'd also like to take a few minutes to recognize some of the Kent team who's here today. The first person I'd like to recognize is our CEO, Pierre Lemire. Pierre really bent over backwards. Now, he knew that this is one of the major wound care meetings in the entire world, and he constantly compliments the size, and the caliber, and the quality of this meeting. And he flew all day yesterday from Barcelona to get here, and we're really happy. Pierre, thank you so much for attending this great meeting. Because it is such a major, significant meeting, and I appreciate your help. I'd also like to recommend someone that I've really grown to appreciate and have a great deal of respect for, Sandra Jenks. Sandra is, she's not even in the room. There she is. There's Sandra. She is our Vice President of Marketing. Actually, I've given her the new title of COO because it's really the role she fills. She's Pierre's right hand. She keeps us all on track, and she's just done an excellent job. And thank you so much for everything that you do for Kent. Chris Shuttle is here. You all know Chris. She's been on the board of the BWC for years. She's been hugely supportive of the organization. And she's on board with Kent as a VP of Clinical Services and Reimbursement. Chris. Moira Siskis is here. Those of you that attended the billing and coding session as a pre-conference know Moira is an expert in that area, and Moira is involved with the company from a reimbursement standpoint. So Moira, thank you. I recognized Erin Bushess yesterday when she received her bachelor's award. She's one of the newest members of the Kent team. We're really happy to have her. She gave presentations this morning that was excellent. And Erin, thanks for all your work. There she is. And then last but not least, I'm going to recognize someone that's not here, but he's really been here because he's been blowing up my phone like every 3 minutes. He's the texture of the group, but Will Seifert, some of you may know the name, is our Vice President of New Product Development. I love Will, work with him closely. He's got these fingers that just won't stop. So he's been here like constantly in my back pocket, but I just want to recognize Will too, so thanks. Really appreciate all of you attending and joining us for the session. I think you'll find it incredibly interesting. As you know, from this morning's session, I love new technologies. This is the reason I really gotten involved with Kent. Kent changed my practice in a big way, and we're going to share some of that insight with you. I'm going to start off by giving you just a real brief insight into what this technology is, and then we're going to really spend some time looking at the clinical connections here, because I think that's really where the value is. We're constantly finding better ways and newer ways of using this technology, and we're going to share some really wonderful insights. So I'll give you a little quick backdrop of the technology, and then we're going to let the experts speak. Chuck Andersen, most of you know very well. He's just a great friend and colleague of mine for years. And Chuck has done some really great work with a young man by the name of Homer, who's sitting in the back of the room. I recognized you this morning, Homer, and you weren't here. I think you probably were out partying last night or something. I don't know. But I recognize you now. I see you there, so I'll give you a round of applause, Homer, for all your work and research in the area. And Chuck is going to talk to us about some interesting things from a vascular perspective in using NIRS. Misael Alonso is also another physician who's really helped Kent a lot. I apologize for the period. It says a comma behind your your name, Misael, but Misael's going to share his insights on hyperbaric. This is one of the areas of passion I have, and I'm really literally excited to hear your thoughts, Misael. And then my dear friend Martha, who closed the party down with me last night. Right after she got off the Peloton bike, she's gonna be sharing some really neat insights on how she's using this technology outside of the wound care clinic and hospital in mobile applications. And I really believe this area is huge for wound care. We're gonna see it continue to grow. And it's really neat to see Martha take applications like this technology to her practice, because you typically don't see it in that setting very often. So those are the introductions. We're not going to spend time transitioning, but I will start off sharing real quick what this technology is. So how many of us have seen wounds like this? Everybody, right? And we look at it and go, yeah, there's biofilm and bioburden and maybe some granulation. And boy, we make guesswork at what we're looking at, and we make guesswork at what's going to work for these wounds. Question is there technologies that we get more information about this wound? And I'm really excited to say that near-infrared spectroscopy is certainly one of them. There are other emerging technologies. Some of them were present here in the conference, and you see that we're starting to be able to look at this tissue in a much more aggressive way and take that information to make decisions. So Aaron shared this thought with you, and I think this is really true. We look at these wounds from the outside, it really is the tip of the iceberg. Everything that's happening below the surface, we have trouble seeing until just recently. So what lies beneath really tells the story. So here's a solution, or at least one of the solutions, snapshot technology. And what is it? Well, it's using near-infrared spectroscopy. Again, we're taking that light between 700 and 1100 nanometers in that near-infrared spectrum, and we're taking and using the utility of that light to image the tissues. The light is shined into the tissues, it's reflected back, and it's captured. We know that oxygenated and deoxygenated hemoglobin will absorb at different frequencies of that wavelength that I shared with you. And the camera is very smart, pulls it back, analyzes it, and it produces a pretty picture for us to interpret. So it's really quick, done by the bedside. Here's again illustrating my other young buck in the audience, Jonathan, who's done a lot of work and research for us. He shines the light quick, just a few seconds of a photo. It then produces this image that then can be interrogated by the bedside on a touch screen to pull up values of STO2, as well as oxygenated and deoxygenated hemoglobin. This is a canned photo, but suffice it to say, you see the tourniquet on the finger, you can see the depressed STO2 where the blood flow has stopped in that digit, but we can actually look at the deoxygenated and oxygenated hemoglobin to really get a much better idea of what is going on in that tissue. So reviewing the interpreted images, red and orange is good, blue and green is not good, and we can again get these numbers and make decisions. There's also analytics, and we're adding to the complement of wound analytics here. Soon we will have not only identification of segment wound, you heard about this if you sat through the AI segment yesterday, segmentation of the wound with measurements. We're going to be rolling out 3D analysis where we're going to be able to do volume analysis, again, largely complemented by AI. So we're trying to provide a one-stop imaging device for clinicians. So the clinical examples we're going to share with you now that you understand what this technology is we certainly use it for surgical decisions, and Chuck might reference a few of these, but he's going to spend a lot of his time talking about vascular imaging and use of NIRS in this space, vascular. Chuck is a surgeon, so I want to make sure that you were aware that we use it in the surgical operatory field as well. Michael Devine has a great poster downstairs looking at how he's been using this in his reconstructive cases from a surgical standpoint. We're going to then turn the podium over to Misael. Misael's going to share his experience on hyperbaric. Again, I'm really excited about this area. I was talking to Tettelbach about getting restorers to come on board with us, really looking at the use of this device in hyperbaric because I think it's a game changer. We can do business much better with this tool. And then Martha's gonna, again, share her insights on wound care from a wound care perspective in a little different setting, the mobile setting. So with that, I'm going to turn the, we have been accumulating evidence. This is not something that is, without some really good published studies, and we're continuing to work on this and put more into the literature to support what we're doing. And then lastly, as I mentioned, Moira's here. If you have any questions, we're not going to talk about reimbursement. We do have codes, and Moira can answer all those questions for you at the end of the session.
Hello, everyone. Thank you for attending. My name is Dr. Misael Alonso, and I practice in Goodyear, Arizona. So I'll be discussing using snapshot NIR using hyperbaric oxygen therapy. So at my clinic, it's a hospital-owned wound care clinic, so we can only dive for certain indications: compromised flap or graft, chronic osteomyelitis, acute arterial insufficiency, soft tissue radial necrosis, and of course diabetic foot ulcers, but Wagner grade 3 or higher. So this next case is very special to me. When I called a patient that I was gonna present his case at this meeting, he was more than happy to come by to my clinic so I could videotape. Almost a year and a half ago, he was told that he required a right below the knee amputation. Snapshot NIR imaging helped me to extend his hyperbaric oxygen therapy. So this is what happened. He presented with a right foot plantar diabetic ulcer. Usually on the first visit, I'll request bilateral arterial Doppler ultrasound with toe brachial index. But he told me, no, there's no need. My cardiologist already did this. And he told me everything was fine. But there was minimal improvement. We did weekly debridements, offloading. It just never improved until one day he came into the clinic unannounced. And he had a huge diabetic foot abscess. So I directly admitted the patient to the hospital. I ordered a CT angiogram of the aorta, bilateral extremity runoffs, and he had severe peripheral arterial disease. In fact, he occluded some of the arteries. So during the inpatient consultation, he was seen by both cardiology as well as vascular surgery. And this is from their notes. The patient will require a right below the knee amputation. The patient declined, so it became a limb salvage. So I asked my orthopedic colleague to help me with a debridement. Thereafter, I placed negative pressure wound therapy with installation dwell using hypochlorous acid. He was placed on intravenous antibiotics. So while he's an inpatient, I call my clinic to obtain insurance authorization for hyperbaric. Now with diabetic foot ulcerations, we usually get approval for 30 sessions, but we can extend it out for 60 sessions, but in 10 dive increments. So on day 30, I took off his wound vac. It was horribly macerated, foul smell, and I'm using molecular here. There's extensive bacterial presence. So I had to do an extensive debridement. Now, at the same time, my HBO tech is applying to get authorization for additional hyperbaric oxygen therapy, but use the post-debridement measurements. So the insurance company says, hey, this patient is not improving with hyperbaric oxygen. We're going to deny any further sessions. So this is the time when I first obtained my snapshot NIR imaging. And the way I would use it is I would take a picture before the patient went into the chamber and immediately after he came out of the chamber. And I did this every day. So I was able to set up a peer-to-peer review with the physician at the insurance company, but I requested to email my pictures so that she could see the improvement in oxygenation after the patient came out of the HVO chamber. And in addition, I also sent my digital photo measurements showing the true surface area. And so, of course, she had a few questions on snapshot NIR imaging, but the patient was approved for 30 sessions extra. This was day 54 of hyperbaric oxygen therapy, and you can see he's healing. And then the patient's wife, again, in the anticipation of this presentation, sent me a picture of the patient's foot, fully healed. This was another inpatient consultation. This patient actually had bilateral foot ulcerations, actually Wagner grade 4. So he got debrided, and just like I did with the first patient, we obtained insurance authorization for hyperbaric oxygen therapy. And so this is day 9, and you can see that he is responding to hyperbaric oxygen therapy. Soft tissue radiation. So we know radiation is great for killing cancer cells, but it can harm healthy tissue. And sometimes we don't see this until weeks, months, years later. So this patient was referred to me because her right breast had 3 tunneling wounds. You can see 2 of them there, but the other one's medial. So in addition to weekly debridement, application of cellular and tissue products, she underwent hyperbaric oxygen therapy. She responded and she healed. So this patient developed head and neck cancer and got radiation. A year before he got referred to us, he began losing teeth, and he wanted to get dental implants. But if a dentist or oral surgeon does any procedure on radiated tissue, there's a high risk for osteoradionecrosis. So we implemented what's called a March protocol. So the patient comes in, we dive the patient 20 sessions at 2.4 atmospheres, then they get the dental procedure, and then we do 10 more hyperbaric oxygen therapies. But I wanted to see if I could prove that this works. So I would take my snapshot imaging, I would take a picture of the right side of the face, left side of the face, inside the mouth, both sides, and the neck, before and after he came out of hyperbaric oxygen therapy. And I could see that, yes, he was responding to hyperbaric oxygen. This poor lady developed 2 types of skin cancer, a basal cell and then an invasive squamous cell carcinoma. It's hard to see her, but she's missing her eye. She had a complete resection of the nose. But she was referred to me because the plastic surgeon was concerned that the flap he placed was failing and there was exposed bone. So we put her in hyperbaric oxygen therapy, and we can see she's responding to it. This is one of my most challenging patients. So I've known him for years, and we were taking care of him for venous ulcerations. But one day he came into the clinic, and we noticed on the right foot, 4th digit, it looked like a fluid blister. And within 1 to 2 weeks, it extended out. And then if you look closely at the 4th and 5th digit, it's very indurated, like dry gangrene. So directly admit him to the hospital. He undergoes a CT angiogram of the aorta, bilateral extremity runoffs, and he has acute thrombus of the arteries. He undergoes revascularization by the cardiologist, but since it was so extensive, this is followed by a vascular surgeon. And because this is an acute event, we want to get the patient to hyperbaric oxygen therapy quickly. But there was a huge delay. So I live in Arizona, the clinic is in Arizona, the patient is in Arizona, the insurance card says blah, blah, blah of Arizona. The appointment's set for 12 o'clock. I get a voicemail. Dr. Alonso, you missed your appointment. It was 10 o'clock Central Time. I had to reschedule for another week, so this patient didn't get in on time. And if you look closely, we don't really see improvement of the oxygenation levels. But we were able to do 20 sessions, and then this happens.
Oh.
So I have to directly admit the patient back to the hospital. We repeat the vascular studies, and he included more arteries. But by this time, we can't save his toes, so he needs a transmetatarsal amputation. The good news, if you will, I can requalify for hyperbaric oxygen again because it's another acute arterial event. But by the time we got him started, he had a significant dehiscence. So at this point, I wanted to do everything possible. So I also implemented continuous diffusion of oxygen in addition to hyperbaric oxygen. And I can see, okay, now he's responding. This is the patient last week. So this patient, I used snapshot NIR imaging for two reasons. One, I was able to detect critical limb ischemia. So I immediately sent him to my vascular surgeon colleague. He got revascularized. But a few weeks later, he had severe pain in the leg. He had to go back to the hospital. He clotted off the artery. So that's the bottom picture. So again, I can dive him for 20 sessions, and I can see that he's responding to hyperbaric oxygen therapy. So this poor patient developed a hemorrhagic cerebral vascular accident of the thalamus. It was mostly bedridden in the hospital, and upon discharge to rehab, they didn't really move him. And so he came to my hospital septic. It was because of an unstageable sacral pressure injury. So we had to do surgical resection, but both the MRI and bone biopsy confirmed not acute, but chronic osteomyelitis. So at that point, we were able to dive him. This is comparing day 4 of hyperbaric oxygen therapy with day 51 of hyperbaric, showing improvement. Now, there are cases where snapshot NIR imaging has proven that, hey, the patient is not benefiting from oxygen therapy. So the chronic host versus graft. This poor lady developed acute leukemia. So we irradiate her bone marrow. Her sister donates her bone marrow to the patient, but that bone marrow attacks the patient. And so she had severe ulcerations of the lower extremities. She's mostly blind, severe scarring of the skin. So despite hyperbaric oxygen and continuous diffusion of oxygen, she didn't respond. The other patient was a diabetic foot ulcer, but he actually had good vasculature. The issue was his anatomy. So in conclusion, I've used hyperbaric oxygen therapy on almost all of my hyperbaric patients. It's proven a useful tool to show me if the patient's going to respond. And it helped me with several peer-to-peer conversations to get patients extended for hyperbaric oxygen therapy. Thank you very much.
Good afternoon. I'm Chuck Andersen. I'm from Madigan Army Medical Center. For the past 25 years, we've had a very active limb preservation program. It's very unique because in one physical location, we have vascular surgery, we have advanced podiatric care, we have wound care, we have a vascular lab, a co-located, and because money doesn't turn the wheel in a military facility, we can get immediate consultation and immediate treatment. Dr. Mario Ponticello, Mario, stand up please. So Mario is our current chief of limb preservation. Homer, stand up. So Homer is the co-author here and has done a lot of, he's a research assistant with me, and he's done a lot of this work. Thank you. The foundation has really been set for this lecture, and I think, Aaron, I really appreciated your presentation. So I'm going to skip over some of it and try to get some highlights of what I think is really important. So first of all, critical limb ischemia. The problem is if critical limb ischemia is not recognized early, then what happens in addition to maggots? You can go on to sepsis, you can go on to gangrene, and you can end up with an amputation. So the key is early identification and treatment of critical limb ischemia. There have been some very nice papers in the literature, a very good one from Denver that really demonstrated delay in recognition and delay in referral to a limb preservation center leads to a much higher rate of amputation. So traditional methods, I just want to make a couple of points there. The ABI, and I said this the other day in a presentation, the ABI is very, very dangerous. I know it's used in a lot of centers for screening, but it's very dangerous. It's dangerous because it's misunderstood. The ABI measures pressure at the ankle where the cuff is, not where they're listening with the Doppler. So an ABI gives you no information at all about the foot. Very important to understand. The other thing is, with many of our patients, especially diabetics, patients with renal failure, their arteries are calcified and the numbers you get are falsely elevated. So be very, very careful with ABIs. Our go-to in the past has been toe pressures, toe waveforms. As Aaron pointed out, they're very useful and can give you information about the toes, but the wounds may be in a different angiosome and may be ischemic, and the toe pressures or toe waveforms are going to miss that. So there's an entity called regional ischemia of a wound, which is a real entity. So you can have ischemia in a wound and very normal vascular study. So traditional methods, although useful, have some limitation. Homer put together this slide, and I think it's a very important slide, that when you look at the common methods used to diagnose PAD and to substantiate critical limb ischemia, there's an awful lot of money spent. And perhaps using the NIRS, we can cut down on some of that cost. So we've heard from Jeff and other people how NIRS works, what it looks like, and what the studies, how they're evaluated. This may be the most important slide, and this is from my experience as a vascular surgeon. So when you have critical limb ischemia, these patients come in and are seen in the emergency room, and they have a red foot, and they're diagnosed as cellulitis, and they're put on antibiotics. That red foot is dependent rubor. It's critical limb ischemia. It's missed because the red foot. So the same thing can occur again when you're looking with NIRS. So what we found in vascular surgery is dependent rubor, but power on elevation. So what I tell all of the residents is anytime you see a red foot, put it in the air. If it goes very white, power, then it's critical limb ischemia. If you're suspicious of cellulitis and you elevate it and the rubor goes away, it's not cellulitis. So very, very important. So based on that finding of power on elevation dependent rubor, we designed this test, and it's called the leg elevation test. So what we do is we scan the foot in the supine position, and then we elevate the foot for 1 minute, and then we rescan, and we document the change in oxygenation. The key, probably the take-home message of this talk, is that critical limb ischemia can be missed with routine scanning with NIRS. Let me say that again, because this is great technology, but critical limb ischemia without using leg elevation can be missed. So I'm going to present quickly a couple of cases. This is a 66-year-old diabetic female. She'd actually been treated by neurology and neurosurgery because her pain was felt to be related to her back. We performed a NIRS exam for PAD. It was positive. We did a Doppler study, and she had biphasic to monophasic signals in the DP and PT. But this is the key. So you look at supine, and you look at the oxygenation, and it's a little down. It's high 70s. That can be normal. But when elevated, what you see is now the oxygenation level is 40 to 50. Significant ischemia. So this was the patient's wound had been present for a long time. It occurred as a result of a biopsy and stayed present because of a misdiagnosis. So the patient was revascularized successfully. And now you see supine, which again, good numbers, but with elevation, you maintain numbers 70, high 70s. So this is successful revascularization, and the patient went on to heal the wound. This is another study, a 58-year-old female with alpha thalassemia complicated by critical limb ischemia. Anterior tibial ulcer developed after a left popliteal artery bypass in early 2022. The bypass unfortunately thrombosed postoperatively. The patient was not having any claudication at that point in time, and it was decided to just watch the patient's vascular status. Unfortunately, her wound failed to heal, so we relooked at her both with NIRS and vascular studies. And here's what you see, but again, you look at the supine position, not too impressive, but you look at the elevation, very impressive ischemia. So she was taken to the operating room. Interestingly enough, although it had been a significant length of time, we were able to get a wire across that thrombosis, recanalize that thrombosed popliteal graft, and restore flow. So this is post-revascularization, and you can see with elevation that she has maintained oxygenation. So this is a study that we performed to look at how useful or what kind of information we could get with the leg elevation test. So patients suspected of vascular disease, they were scanned with their feet in the supine position, both plantar and dorsal part of the foot, and then they were rescanned after the leg was elevated, as you can see the photo there, for 45 degrees for 1 minute. And then we rescanned both the dorsal and ventral or plantar part of the foot. Just to note, the plantar scans are the most accurate and easy to read, and especially with a pigmented individual, you can still get data looking at the plantar scan. So we recorded supine oxygenation and hemoglobin values. Excuse me. We recorded elevated oxygenation and the hemoglobin values compared the elevation with the supine values, and then compared the data that we had from history, physical exam, and vascular studies. I reviewed all of those personally and put them into a category based on a clinical diagnosis of whether they were normal, mild, moderate, or severe. So these are our results. 57 limbs assessed in 34 patients, 17 were normal, 9 16 moderate disease, and 15 severe. What's outlined in red, again, is the take-home message. Supine resting STOT was not statistically different between normal, mild, moderate, and severe disease. Again, a limited population, but it shows the limitations of scanning only in the supine position. These are the results. This graph really tells the story if you look above. So you can see the oxygenation levels in normal are higher. Unfortunately, a small study, not statistically. The mild and moderate, the same. And the scary thing is the critical limb ischemia was also the same as mild and moderate. What you see, so if you look at the far right on the upper graph, this is the meat. That with elevation, what you see is the normal stays oxygenated. The mild and moderate go down. The moderate more than the mild. But the critical thing is the critical limb ischemia goes down. So that's how you pick up the critical limb ischemia. You can see the photo underneath. You look at the image at the supine position, oxygen normal, with elevation, critical ischemia. So severe PAD, you can see the difference between the supine and the elevated. Mild to moderate, again, goes down a little bit. And normal stays normal. So, two very quick studies to just illustrate on top of the clinical studies that you just saw. So this is a patient that came in with a pressure ulcer over the fifth metatarsal head. And what kind of information can you get? You can see the inflammation. So hyperoxygenation is a surrogate marker for inflammation. So you can see the increased oxygenation over the area of the superficial ulceration. But then you see the surrounding tissue and you have reasonable oxygenation. So looking at this, you would say that this is a patient that, number one, has mounted a very good inflammatory response and will go ahead and heal as he did. Another case, this is obviously a plantar diabetic foot ulcer with an infection. So what kind of information can you get? If you look at the third toe, clinically, it doesn't look so good. If you look at the NIRS, it looks even worse. So again, you can pick out that third toe is indeed significantly ischemic. You can see that the patient, again, is mounted an inflammatory response. You look at the surrounding tissue, adequate oxygenation. So based on this alone, you could say that this patient can go to the operating room, can have an appropriate IND debridement of non-viable tissue, and go ahead with a third toe amputation. So in conclusion, NIRS assessment in patients with critical ischemia can be misleading if only performed in the neutral position. The good news is, the very good news, is NIRS with leg elevation test detects critical limb ischemia. So this is point of care, takes only a few minutes. It takes only an additional minute or so with the elevation and then to repeat the study. This work has been accepted for publication in the Journal of Vascular Surgery. We're just reviewing the last edits. So thank you for the privilege of the floor.
Hi, I'm Kelso. I'm the CEO and founder of Wound Care Plus. What you're going to see is a little bit unusual and somewhat interesting for two reasons. Number one, this is from 2 years ago. And the reason I developed this slide deck was because I was asked to present to Medicare about our data. The problem was we didn't have a lot of data because we weren't using near-infrared spectroscopy very much. We weren't using it because the payers had not decided to pay. So we did a trial with Kent Imaging. We rented the machine for about a month and a half. I put it in the hands of our providers so that we would have some form of evidence to go to the payers and say, here's what we're finding. We only used it for about a month and a half. It was about 140 patients. And then Medicare called and said, please present your data. I was not prepared. I had 3 days to get something ready. And the only thing I knew to do was to go through our database on those 140 patients and just present the data like it was. There's no inclusion, there's no exclusion. Everybody you're getting ready to see was everybody we did this technology on. Good, bad, or ugly, let the cards fall where they may, okay? So what you're gonna see are the actual slides that I presented to Medicare. It's interesting because I've been doing advanced wound care for a little over 20 years. When you've been touching patients that long, you have inherent beliefs that nobody's gonna be able to change your mind on. I've been doing post-acute now for a little over 10 years. I can tell you my inherent belief is the majority of elderly population have venous arterial mix. They've smoked for 40 years, they have bad genetics, maybe they were truck drivers for 30 years and sat, maybe they were the meat butcher that stood on their legs for 30 years. They were obese. They have the sickest of the sick. On average, 40 to 50 ICD-10 diagnosis codes on the chart before I step forward and touch them, and the majority of them have at least 20 medications, sometimes 40 or 50 pages of polypharmacy, which means we're not gonna sharp degree a whole lot. And if we do sharp degree, we're gonna pull our punches because my inherent belief is these people have significant arterial disease where sharp debridement may negatively impact them. This is a little bit about my history, various things that I've done recently and over the years. So the challenges that we experience in post-acute care, we are entrusted to diagnose and treat the nation's retired poor and underserved. I don't have a vascular lab to send them out to. And if I do, it may take weeks to get them in. And then they're 98 and it's 20 degrees outside and they don't feel like going. Or maybe they're sick, or they have a UTI, or they're demented so the family has to meet them there, or the building has to send a staff member. Or we have to use Medicaid transportation, which requires we set it up at least 72 hours in advance. And so these are all challenges that we deal with. Access to real-time diagnostics for wound care is non-existent in this care setting. Additionally, we can order mobile ultrasound, mobile x-ray. They don't do ABIs or TBIs. They don't get reimbursed for it anymore. And by the way, if I order an arterial ultrasound and I need a venous ultrasound, Medicare only pays for one in that week. So I have to order the one that I'm most concerned about, wait a week, and then turn around and order the other one and wait for those results. It's not real time. We deal with the most aged, the most comorbid, most polypharmacy, the most demented. These people have a very real fear of being poked and prodded. Have you ever seen cartoons where somebody gets punched and then they see stars or birds flying around their head? I had that happen to me. I got clocked by a 110-year-old man. He was afraid and brought his knee up and hit me under the chin, and I was standing at the bedside literally saying stars. The best ass kicking I ever had in my life was from a 110-year-old. Anyway, they have a very real fear of poking and prodding. And we know that the fees for diagnostic studies are quite frankly enormous. And so they don't always have the co-pays or the out-of-pocket deductible to pay. They oftentimes can't afford transportation, or transportation doesn't exist, or they drop them off at the wrong hospital. I've had that happen more than once. We know that they have atherosclerosis, venous disease, microvascular circulatory disorders or impairment, and none of these conditions get better with time. So how do we heal the sickest of the sick? And the answer is a lot of times we can't. So we're listing these wounds as palliative or maintenance wounds, not healable because we can't be aggressive. These are the sites of care that we operate in, and I'm always looking for trunk to bed technology. That's my term. If it's 75 pounds, my providers cannot heft it in and out of the back of our fleet vehicles. They're gonna end up with back injuries, and we see numerous buildings a day. Here's the real world evidence. This is what I presented to Medicare. So in our database, when we were charting on near-infrared spectroscopy, Medicare, they care about heal rates, but they also care about quality of life and how does this diagnostic study change your care plan. In order to meet medical necessity for diagnostic studies, these are the questions that we need to answer if we're billing additional CPT codes. Here's what's crazy. The majority of our elderly population, if you do an arterial ultrasound, come back looking like they need a referral to a vascular surgeon. So that's what we would do. And then the vascular surgeons would see them eventually, send them back and say they don't need any interventions. Well, wait, that's crazy. And it got to the point where we were referring so much, the vascular surgeons were shutting us down. We don't have room to see them. We don't have time to see them. We're not going to be able to do anything anyway. Well, that is counterintuitive to what we believed. If they have arterial disease and they have some kind of stenosis, they need some kind of intervention to heal. Well, enter near-infrared spectroscopy. Come to find out, after doing near-infrared spectroscopy, we were able to reduce the need for vascular surgery referrals or interventions down to 0.71% of the time. That's huge, because 60% of the time we believed these people with lower extremity wounds that were aged or infirmed needed referrals to vascular surgery based on the macrovascular testing we were doing at the bedside, the mobile ultrasound companies. With near-infrared spectroscopy, we were able to prove that wasn't the case. So now we're able to refer to the vascular surgeons what they actually need to see and what they can actually intervene on. We also, the need to evaluate for medical necessity of debridements, our providers were doing 22% of the time. So we were able to see that their vascular status, their microvascular status was appropriate for sharp debridement 22% of the time. We could evaluate their circulation or oxygenation and perfusion 15% of the time. This is what the providers are saying that they're using near-infrared spectroscopy for. Here's my thought process, here's what I want to know. Here's how this device is going to help. Notice that 90% of the time, it was to follow up on the trends of the tissue, and 99% of the time, it actually impacted the treatment decisions and care plans of these people. That's insane. Sharp debridement we know is contraindicated for numerous wounds. Palliative wounds, diabetic wounds with suspected blood flow impairment, arterial wounds, mixed etiology, malignant wounds, and flaps or grafts. So how do you decide at the bedside real time, whether or not sharp debridement is indicated or contraindicated when we don't have access to real-time diagnostic equipment? 84% of the time they were using near-infrared spectroscopy because the ulcer had not improved for longer than 2 weeks. So is it infected? Is it because there's biofilm? Is it because we have a perfusion issue? That's all information we need to know if we're going to set up an adequate care plan with the intent to heal. 41% of the time they were using it because there was skin changes around the wound that were causing areas of concern. We had dusky color, we knew we had mixed vascular disease. Some of these people had a diagnosis of diabetes for more than 5 years, which means potential for atherosclerosis or severe atherosclerosis. Some of these people had a history of heart attack or large vessel occlusive disease and peripheral arterial disease. These are all underlying medical factors or symptoms that we need to consider before we go into an aggressive treatment care plan on the elderly. Does that mean I'm out of time? Is it time for the dance party? Just me? Okay. So results of the imaging of the microcirculation and oxygenation impacted treatment in the following ways. 85% of the time we were able to determine that the area of perfusion was adequate. 85% of the time. We would have thought it was 15 to 20% of the time in the elderly lower extremities. We knew that we needed additional blood flow studies 7% of the time. The translation is we're now saving payer dollars because we're not ordering additional diagnostic studies that were not medically necessary. We were able to reduce it down to 7.14%. Additionally, we had times where we had the wound listed as healable, and it wasn't. So we had to change the care plan to a palliative wound. That happened 1.5% of the time. Notice that 13% of the time we had the wound listed as maintenance or palliative, and in fact the wound was healable. So then the providers were more comfortable to be more aggressive, and those wounds went on to heal. And 2.14% of the time, we referred to a vascular surgeon to be able to do surgical intervention.